So I would like to officially welcome you to the September monthly webinar with AHA Team Training, Innovative Care, the Value of the Virtual Nurse in a Pediatric Hospital. My name is Rachel Vandervoort. I'll be the moderator today. And just a few rules of engagement and some housekeeping stuff to get started, and then we will hand it over to the presenter. So hopefully you have your audio already sorted out, but just calling out, there are two options. There's joining with computer and joining via phone. You should be able to adjust that in the toolbar at the bottom of your screen. Like I said, the chat is active throughout the presentation. You have the option of chatting to everyone or just sending a message to the hosts and panelists. So if you just look at the top of that chat box, there should be a little blue box that either says everyone or hosts and panelists. So that chat will be active, both channels throughout the presentation. Feel free to chat in questions both related to technical assistance, resources, or anything you'd like to hear from our presenters. I'll be gathering up the questions for our presenters and getting to those at the end. Otherwise, note you will be in a listen-only mode, and this is being recorded, but the only thing that will be captured is the presentation screen. The chat will not make the recording. So those of you that are joining us today, you have the benefit of earning 1 hour of CE credit. Hopefully you already have your Duke OneLink account set up, but if not, we have some instructions that Kara will drop into the chat along with today's slides for people to follow along. Biggest thing you need to do after you have set up your account is text that code to the phone number shown on the screen. And I will, again, go over those for our listen-only people at the end of the presentation. But that is FATDUR, texting to 919-213-8033. So just a quick window into what else is going on in the team training window. We do have a few in-person Team Steps Master Training courses left for this year. Very excited to get those filled up and promoted. Next webinar on our schedule is one centered on culinary food choices in the hospital setting with our sponsors from the Physicians Committee for Responsible Medicine. So that registration is open on our webpage. And the other area of our program that I'd like to highlight, as always, is our advisory services. So beyond the free webinars and the public courses, we really like to work one-on-one with teams and organizations to meet your training needs and your Team Steps goals and just work very mindfully, consciously aligned with clients. Again, more information on our website, so feel free to check us out there if you have any questions or interests. So with that, let's get into the meat of today's presentation. I'm going to turn it over to our presenters, Liz Salerno and Sophie Rodriguez with Nemours Children's Health. They're going to talk to us more about the virtual nurse program.
Thank you, Rachel, and thank you, AHA, for this opportunity. Certainly privileged to be here and share a rewarding story for us, an adventure that we've been on and we continue to be on every day. So our objectives for today's webinar is to identify opportunities for the virtual nursing model, demonstrate knowledge of the process of initiating a program and tell our story of how we got that done, and hopefully answer any questions to help you if you're on this journey as well, and evaluate the outcomes for the virtual nursing program. A little bit about us. So Nemours Children's Health is one of the largest integrated children's health systems in the U.S. We're proud to have 2 freestanding pediatric hospitals pictured here, one in Delaware and one in Florida. From our stats, we are in 4 states completely, have about 1.8 million encounters with patients, and really proud of the work with our associates, the growing number of staff that we have, the outreach, the research funding. And Nemours Kids Health is one of the most viewed websites for dependable information of children's health overall. So proud of the organization's devotion to improving the care of children and their well-being. So virtual nursing. I don't think probably anyone on this call has not heard this phrase or some, sort of exchange of what it's formed, it's an emerging technology. It's rapidly being adopted in healthcare, mostly in the adult systems. So we are freestanding pediatric, like I've mentioned, so trying to figure out how to do it for us was new and innovative. The pandemic certainly impacted the way we deliver healthcare. Also with the staffing challenges that I'm sure we've all had, there was an opportunity to do things differently. And that's really where this emerging technology came through. Florida's hospital opened in 2012, our second hospital in the system, when we opened with a clinical logistics center. And that's what's being pictured here. It's a centralized monitoring hub for our patients, and we expanded that to Delaware. So we actually have this room available with the centralized patient monitoring and have inpatient rooms and cameras in every inpatient room. So we already were set up from an infrastructure perspective on doing something like this. So as leaders, it was really about finding the right timing. So we know we could do a virtual program. So when do we do it? What's the right timing and how do we get started on that journey? And for us, it was really about listening to our staff, having that right timing coming from them. So once we started to hear staff asking about, hey, virtual nursing, can we do something with that? Could we use these cameras differently to offset some workload from the bedside? And once those conversations were happening in our shared governance councils, we knew that we were ready to start embracing and really working towards a virtual nursing model within our pediatric system. So these were our guiding principles as we embarked on this journey. We are committed to having the healthiest generation of children and going well beyond medicine. So we really looked at that family-centered enterprise approach that was really important for us. How do we do this together in a creative fashion and really becoming that first enterprise pediatric virtual nursing model? Next. So here's the project overview. We actually just celebrated our first year anniversary for our virtual nursing program on August 14th. So we were super excited about that. And it's been quite a journey for all of that. We created a task force once that timing was right, getting our frontline associates engaged with this, in addition to all the ISIT support you're going to need for this and leadership. We planned, we tested, we launched a pilot and have completely shifted now to really integrating this model within our standard of care. Our goal, as you see it there, was really to do this on an enterprise basis, making sure that we had those guiding principles always at the forefront. And we knew about the anticipated benefits, many research articles from an adult perspective. So we knew that there could be things that were translatable into pediatrics. We know about the capacity, the resources, the improving experience, whether that's the nursing experience or the patient experience, were certainly opportunities. There are cost reduction opportunities, waste reductions, all of it. So we certainly set us up from the beginning, understanding that vast array of what our benefits could be from implementing the system and try to capture all that through every step in the progress. Next. So here we are. We launched, like I said, in August 14th of 23. There's some pictures here of our initial virtual nurse program launch from that clinical logistics center and our expansion. And we have been in PDSA cycles ever since through this process. We launched with the technology we had. So I did mention we had the in-room cameras. They were one way. And we know a lot of what virtual nursing is shifting towards is a two-way, but we didn't let that stop us. We launched with the one-way cameras that we had, with the phone systems, calling into the rooms, really trying to figure out in a different way, how can we do the care that we are providing? The decision to pilot this was at an enterprise level. We piloted from Florida. So we had nurses within our Florida system taking care of patients in Delaware too. We had to navigate compact license. We're fortunate to have that available within us, and having those resource books, right? How do we give the nurses the knowledge and those resources to share information from a patient that's in Delaware? So we navigated all of that through the program. And really the success so far has been because the VRNs have made it a success. I can list every single one of them. Their engagement in a project like this, the old and the new, bringing it together, really being innovative thinkers themselves and problem solving is what has made this so successful for us. We did target nurses with about 5 years of experience at the bedside as our initial pilot launch too. Next. So this is the Venn diagram that we put together and really launched with the activities that we considered for the virtual nurse, which ones are going to stay clearly at the bedside, and what could we collaborate on, because it really is a lot about collaborating and communicating for all of those things. We did have, quality as a most importance. We want the patients to be safe in this new model, and what could we do to offset actions by really making them an extension of the care team, a team member that is supporting them, but always keeping first and foremost that patient experience and making sure they're getting the utmost care. They did things, as it evolved beyond the admission databases and the discharge, where really are our primary focuses, that patient throughput. So helping with the admission databases, calling back, we've integrated now social determinants of health screenings that they're doing as part of those admission screening questions, which we always wanted to do. And how are we going to build this in? We've been able to integrate that to the virtual nursing model. They're focused on education. Some of that going through and making sure that it's happening, that it's timely, that it's reinforced, because it's not a one and done, especially with all the education and the information overload that patients and families can experience within the setting. Care plans being updated. I mean, the list goes on and on of the possibilities of what we could integrate, but this was certainly our start to it all and where the conversations took off from.
Thank you, Sophie. So, I think as with any project, it's essential to have key project measures. And we were really thoughtful in the way in which we decided upon these measures. And I think most importantly, Sophie and I, as a guiding principle, wanted to keep the patient family certainly at the center, but also the work of our clinical teams, realizing that this was such a different model. And there was a lot of feels that come with that. And so involving them from the get-go was really crucial to us. And we have since, been successful and have been able to expand because of the work of the clinical teams and having them at the table. So these are a few of our key project measures that I'll talk through more today, but the first really is the virtual nurse activity. This is likened to a Bible for us, and we really knew that it was essential for our virtual nurses to be able to tell their story in real time. And so we created tracking tools for them to utilize on a daily basis, hourly basis, and that helped us really to check act along the way, providing us feedback on, this is not working, or we're not leveraging Epic in this way, or we're finding some consistency with this particular issue or delay in care, or even, from a medication standpoint, we're frequently seeing that this particular medication is, we're having difficulty with, the discharge component of it, et cetera. So it really was crucial for us. I think it was also crucial from a check act standpoint, meaning our virtual nurses helped to design the model, boiling down to even the times in which they were working. And I think that's really helped to feed the success of where we're seeing some throughput improvements. And so here in Delaware Valley, we started on 4 West, and Monday through Friday, we were really leaning in on that more so 11 to 11, 12 to 12 time frame for the virtual nurse to operate. And through the tracking of their activity, that wasn't making a difference. And certainly it was making a difference. So, but we needed to shift in a way because it wasn't meeting our patient and family needs related to throughput. So we adjusted that and now have seen a lot of success around our ability to discharge in a timely fashion. So I cannot stress enough the importance of including the clinical teams at the bedside, at the table, in order to make these improvements. Throughout our project, we've also really partnered with our patient experience teams and have done a lot to drill down within NRC what questions speak to the role of the virtual nurse. We've conducted bedside surveys with our RN teams, our clinical teams, looking at qualitative feedback to both in the moment or at the point of use, and also at regular intervals in order to continue to hear from our teams what's working and what's not working. And then I'll dive a bit into some of the data that's coming out of our EPIC dashboard, which really speaks to overall throughput and the impact of the virtual nurse on that. So first, bedside RN survey, just so important for us. Again, this is a different model. And so you can imagine, and I'm sure you're experiencing, if you're thinking through adopting this model, the feedback of you're taking away, you're not adding. This is removing a physical nurse from the bedside and making teams work tighter, harder. And so we needed that feedback. So we did a few things. Throughout the course of the pilot, we created a, quick, I think, Survey Monkey, point of use right at your fingertips, QR code for our clinical teams to provide us regular feedback. And they used it, and it helped us along the way. We were huddling on a daily basis to start as an enterprise team and really using, a method safety associate equipment format. And that was being fed by some of the feedback that we were getting through that survey. So that was hugely helpful for us to have a quite simple, what's working, what's not working, and any comments on how to improve. So again, very important. We then also conducted a formal 30 and 90-day post-go live survey with 9 different questions assessing the role of the virtual nurse. Is it helpful? Is it creating efficiency? Is it a value add? And we were so pleased that 75% of all respondents strongly agreed that the virtual nurse enhanced the bedside role. You can see some of that data broken out on the side here. The virtual nurse has added resource, giving me the tools I need to do my job. So again, such a different mindset than what some feedback that we were getting from our teams related to some of the fear around incorporating this model. And then also as, a leadership team, what we were fearful of when we looked at overall, staffing. I think I saw that as one of the chat comments. Staffing, I think, is a word that we probably use, 15 times in the course of a 12-hour shift, maybe even more. And so again, the impact this had on staffing and adding as a resource and improving efficiency was just so wonderful to hear that from our clinical teams. Nice quote there. The virtual nurse elevates the role beyond what I could have imagined. So we're just extremely pleased with that. So then we, just as importantly, if not most importantly, what's at the center of everything that we do, we partnered with our inpatient experience team to look at our NRC survey responses. So NRC is our mechanism in which we collect data on patient satisfaction. And so in talking through this with the inpatient experience too, we were able to identify these 4 questions here that are on the screen as those that really do speak to the role of the virtual nurse and their importance as part of the care team in, how they're communicating, in their just in general listening, etc. And so those 4 questions are comfort talking with nurses, treating you with courtesy and respect, nursing explaining things, and then nursing listening carefully. And so I'll say we also conducted a survey through our Nemours Children's platform, and we were able to get 320 respondents participate in that survey, essentially introducing a virtual model. And so we wanted to hear from our community, how would this be perceived? Would it be an enhancement? What are your fears and concerns? And there were some concerns, and we tend to be glass half full people. And so when we first read the feedback, it was a oh my gosh moment. We have such passion around this. This is such a value add for our patients and families, and we want to see this be a success. But in that, we learned a lot, and we're able then to get out in front of that as we're introducing the virtual model. And so what we heard was that from our patients and families, there was a worry about that lack of face-to-face interaction. The nurses, nursing as a profession, we're really one of the most trusted professions. And so to work with someone over the phone or on a camera didn't feel as personal. Families were concerned about the discharge process, the admission process. Is it going to be clunky? Do I have to repeat everything again? What does that handoff look like between the actual physical nurse that's caring for me versus the virtual nurse? Is it going to be a seamless transition? Concerns about privacy, talking, sharing my information to some virtual person, who's not someone I can interact with, having my, screen up there and what's going to be shared, what's out there from a virtual perspective. And again, we live in a different time. So also a concern of, are you going to put an AI generated image, or are you going to put a chatbot up there and that's going to be the person that I'm acting with, and losing that personal touch and personal connection with your care team? So again, really good questions that came across to us to help inform not only the success of the model, but also things that we needed to get out in front of and make sure that when we're highlighting the virtual nurse role, when we're introducing the virtual nurse, that we are addressing some of these concerns. And so then the meat, you talk the talk, but you walking the walk. We are seeing that our scores are significantly above baseline on all 4 measures, ranging from 6 to 9 points. And so we try to highlight where we're seeing improvement. Patients and families are reflecting a higher level of comfort talking to nurses, and nurses are explaining things and listening carefully more often, which again, this resource perspective, we're slowing down to speed up in a way. We're slowing down to make improvements, to make sure that we're having meaningful conversations, that we're really listening, that we're setting up the patient and family for success when they're discharged home. We're really taking the time to do education. I was laughing with one of the virtual nurses the other day. We're going to talk a little bit about our camera integration, but she has a nose Frida available as a picture to pop up, which, if you have children or a pediatric nurse, that's a golden tool to have in your pocket. And so not just talking about it, but being able to show it on the screen and what it looks like and how to properly use it and clean it and all these things. And so, we might not have been able to do that at the bedside with, managing our other patient populations or, et cetera. And so that slow down opportunity for us has been huge. And as you can see here, extremely impactful. So health equity, obviously, top of mind and so important as we look to providing consistent care across all populations of children with, different language needs. And this was just such a win for us. Knowing that in general, Spanish-speaking families report lower satisfaction in comparison with English-speaking families, we knew that it was absolutely essential to provide clear communication, using interpreter services, taking time to answer questions and streamline the experience to prepare for discharge. And we've been able to accomplish that with this virtual model. And so we're hearing from our families through NRC, over 80% of both Spanish and English-speaking families report a positive impact of virtual nursing. And then this is just heartwarming for all of us who are so committed. Scores for both Spanish and English-speaking families were the highest for nurses are treating me with courtesy and respect, and overall showed the highest for nurses listening carefully for our Spanish-speaking population. So again, that ability to really slow down, make sure that we have the interpreter on the line, that we're going line by line on medication education, discharge education has been so helpful. And, I think at times, working clinically, the interpreter is such a key member of our team, but at times stretched thin and really trying to meet the demands across the hospital. And then it can be a little clunky being on the phone with interpreter services or using an iPad. This just feels like a conversation. It feels very seamless for our families. And so we're just so pleased that not only do we feel good about it, but our families are reporting the same. Then we're talking about social determinants of health, leveraging the role of the virtual nurse to complete that screening, again, has been huge. And taking time to really go through all of the screening questions as part of our admission process to make sure that that family is getting the resources they need before their discharge. So the virtual nurse initiating referral and having the tools to be able to share with families, where our closest food pantry, et cetera, is as part of their discharge preparedness. This is something that we continue to work towards because we realize that we have huge opportunities and the virtual nurse has a really key role in this. And so our partnerships here to continue with screening from an enterprise perspective is an absolute future state goal for us that we want to build upon. And when we think about a virtual care team, how they could actually impact, what positive screens we're getting from the social determinants of health. So an Epic dashboard. This was a labor of love, but we got there. It took a little bit of time, a little bit of finesse, and we're so appreciative of our teams in NEI who helped to build this with us. I'm going to talk today a bit more about our medication education, our completion of, our length of stay and readmission data, and our discharge efficiency. But we're continuing to add to this dashboard and show really the impact of the virtual nurse on overall throughput and readmission. The admission database, I'll say, I didn't share the screen here, or I didn't share data around this, but the virtual nurse is really owning that admission database. And so as within our organization, we pull patients from either the emergency department or from other areas, perioperative services, as a nursing team to the bedside so that we really ensure that smooth handoff, a safe handoff from nurse to nurse at the bedside. And so you can imagine as you're pulling a patient, you're walking through the halls, you're really trying to highlight, this is where the cafeteria is. And, let me start some of those screening questions. And so our clinical teams just got so good at completing that admission database. But we wanted to leverage, how can we do that differently? How can we maybe make improvements upon that? So the clinical teams continue, the nursing team continues to pull patients from the emergency department. But then once they're in the room, the virtual nurse is logging in and completing that admission database with them to make sure, again, social determinants of health screening is taking place. We're really diving into each and every one of those questions and making sure that when the patient enters the room, they're very comfortable with not only their care team, but locations of things throughout the hospital, the way in which the expectations that they would have, and then some other things like IV education and your child has an IV and we are really committed to preventing infiltrate, and so these are the things to look out for, and this is how to get in touch with us, and you are an important part of your care team, so we want you there when we're doing rounds. And so again, slowing down in order to provide a really excellent experience, but also to be more efficient and speed up in a way. So first here is education compliance, and this is showing a graph of the first dose medication education completion. And you can see from 2022 to 2024, just an absolute spike in this. So, again, the virtual nurse has the opportunity to look through the meds the patient is receiving, make sure that they're covering all the important parts of that particular medication, what to expect maybe at home if the patient is going on home at prescription, answer any questions, and again, try to start to do this before the last minute. So first dose education, absolutely key, but also preparation for going home and how to manage or answer any questions in order to make sure the family is comfortable with delivering that medicine at home. Discharge efficiency. So this, and then the next slide around readmission, just again, I said it already, just warms my heart, because we were concerned through this that we're gonna, maybe slow things down potentially from a discharge perspective, or that we're not gonna impact efficiency away, or potentially are we gonna see an increase in readmissions? And so what you see here on the screen is from 2022 to current day 2024. We are more efficient with our discharges. So within the Nemours organization, to give you a frame of reference, we have a goal of 60 minutes from discharge order to actual discharge. And so that's what this is really referencing on average. The time has just decreased from that discharge perspective. And again, if you can imagine, that collaboration with the virtual nurse, that seamless care delivery, to be able to go through the discharge instructions, walk through everything, answer any questions, and then reach out to the physical nurse to say, room 24, this patient, has been given their discharge instructions. They're ready to go. I printed it for you. It's on the computer for you just to take there. Family's able to leave. And so again, that waiting period, that wasteful period at times, it seems, we're able to close the gap there. And then this ties exactly into readmission rate. So again, we're seeing that despite the fact that we're more efficient with discharges, it's actually positively impacting our readmission rate, and that is trending down, which is huge. I want to just do I should have said this from the beginning, but one thing to add to this is that within the Delaware Valley, we have 2 units, soon to be 3, who have the virtual nurse model. And our med-surg units are such that one is heavy in churn and throughput. And so we see essentially half the unit go home on a daily basis, and then the other unit is a bit more of your chronic med-surg population, where discharge education, medication management, et cetera, is more complex. And so I included both populations in this data, despite the fact that we are newly up and running with that more that second unit. And we're still seeing success around this. We're still seeing data trend in the right direction, which again is huge for us. And we hope to continue to see these trends as we expand to our rehab unit, hematology oncology, and then our step down unit throughout the Delaware Valley. And Sophie, over to you.
So with all of that, lots to share, talked about our journey, the data. We love to be able to share the data and see that it's trending in the way we want it to trend. But there's also a lot of lessons learned. And that's really hopefully to share some of those takeaways of what we've gone through, the would have, should have, and maybe do it differently. The staffing model, there really is no right staffing model for the virtual nursing program. It's going to be whatever fits within your organization. When we first started and launched, we did the Monday through Friday, 10 a.m. to 10 p.m. as that sweet spot. We were really honing in on our high volumes of turn to start that. But we've adjusted, as Liz mentioned, we stayed with those hours within Florida. They adjusted a little bit within Delaware. So it's going to be whatever fits for you. The question about where do virtual nurses sit? Are they at home? Are they within the, on the units? What does that look like? We started off centralized. So they were in that clinical logistics hub that you saw on the screen, and they did both hospitals. As we branched and grew and expanded the program, now each hospital has their own virtual nurse hub. Ours continues to be in Florida in a central location. So we have the virtual nurses centrally located. They are not remote workers. They work within the hospital setting, and they have shifts within a virtual nursing, which I'll expand on. And then Delaware has them within the units, as you've heard. We have different hospital licensed bed counts, so the expansion is different for each of us. For Florida, we've expanded the program, so now all acute care patients are covered by virtual nurses, still Monday through Friday, 10 a.m. to 10 p. We chose to use our staffing resource pool to have those interested to cross-train as virtual nurses. So in our program, the staffing resource pool is the area that staffs that virtual nursing. They still do clinical shifts at the bedside, and they rotate through the virtual nurse shifts. So that's our model that's worked for us. In Delaware, they chose more of a unit-based model. Each unit, has nurses that are in these virtual nurse roles. So a different approach, and it's working, for each of us for different reasons. So I think there's not a one size fits all, and that's certainly a key takeaway. It's taking a look at your infrastructure. What is the easiest way to do this, or what do you think as a more realistic pattern just to launch? Because it might change over time. We're not saying that it's going to stay centralized for us. I don't know. I think growth and expansion will have to continue to adjust as these programs continue to grow and see what that looks like. Importance, we have ratios. That's a conversation that people ask sometimes. What is the right mix of ratio for a virtual nurse? We happen to have 18-ish bed units within the Florida system. Delaware is more 24, but we still have one nurse for a unit almost. So we're in that range. I think safely we'd say we're about a 24 to 26 range for a virtual nurse. But again, that's all what works for your system. There really isn't necessarily a cutoff. We have certainly found that low 20s is probably the sweet spot that we would aim to stay and not really go too far above that. Holding true to the model, that's hard as well. We've been in situations where there's going to be the questions that we're short on a unit. Can the virtual nurse be in staffing, right? So those are conversations to continue to have and to have leadership support. I think we've gotten to a place where the value of the virtual nurse has really been felt. So they're opting that we keep that virtual nursing program running. If you have one or two, does one go? Again, those are all conversations that need to be transparent within your organization. We currently in Florida have 2 virtual nurses Monday through Friday. So if there is a staffing crunch in the floor, perhaps for a few hours, one of them could be pulled, but we wouldn't pull both because of, again, the value that we're finding within that program. So it's what works within your system. The results, this was certainly something that we did not anticipate. Now, you can see the anticipated benefits from the literature, right, that are published from the adult perspective. But what they don't tell you, sometimes launching a program like this could be peeling an onion or opening Pandora's box for analogies, because you just don't know what you don't know until you do it. And there were results that we were finding, or just overall findings from the virtual nurses from a quality discharge perspective, like, oh my God, we had no idea this was happening. Duplicate meds being on the AVS, printing, we had to really deep dive. Why are things printing and we're not realizing that this duplication is happening, or errors within the documentation? There was so many great catches. And we really had to make sure we started to share that story too, to help us with that culture shift. The culture shift is going to be a challenge in any organization. You're going to have your early adopters, you're going to have resistance, and you're going to have those that until you prove that this works are not probably going to buy in. So we really made sure we shared those great catches and got into a system of finding how we do that. Now, transparent, we were reactive because we didn't even think through that. Once it started surfacing, like, oh, wow, we need to put a system in place to really share these stories, capture them, and have them also to help our quality improvement projects. A lot of initiatives that we've launched have been from the trends we've seen with the virtual nursing. So really thinking through a structure and being able to do that will help. We did, as Liz mentioned, use our daily management system for our virtual nursing and continue. So we continue to meet on a weekly basis now instead of daily, but to talk about, all right, what are your challenges? What are you seeing? What are the wins? And continuing to capture and not lose sight of the initiatives and the improvements. Engaging key stakeholders, I call that out a little separately because you don't realize all the stakeholders in an initiative like this. From a Florida perspective, we really had to go back almost and start bringing in the residents on board. There were a team that it was more of informational that we're launching, but we didn't think of engaging them within that build. In our mindset, we were launching a nursing model of care change, right? So we didn't even think of the extent to which they had input or having to understand in order to align and just get with the improvements and with the changes that we're going to need to improve upon. So I think that getting them engaged sooner was something I certainly would do differently for anyone involved. It's a partner. It's a partner in the support of the program and a partner in navigating the challenges, and also, separate realities. there are different perspectives on what you feel, you see, you do, and getting the disciplines to talk about it and understand and do that is significant to this. So a lot of the quality improvements, a lot of the great catches we continue to share, and like, you know, the expansion of this project, we continue, and I'll talk about that more. And those projects are going to take everyone, you know, to do this together to make sure we're having the best outcomes for our patients. So next steps, exciting next steps for sure. So we continue to develop a plan for sustainability and full-scale models. As I've mentioned, we've got our acute care covered now. Well, now in Florida, we're looking at virtual ICU and really thinking through what does a PICU virtual nurse look like, and what can they do differently? What are those priorities? What do we, you know, what does their Venn diagram settle in? So we're just starting that conversation, but really excited to hopefully by the end of the year launch that. The other is virtual care. So we talk about virtual nursing, but we're shifting that language to talk about virtual care models. There are many other disciplines that could be incorporated into this model successfully. So we are working with pharmacy now to engage them in virtual care, and hopefully by the end of the year, we'll have a model in place. Our aim for pharmacy is med reconciliation, that admission med reconciliation, or that discharge med reconciliation. How can they be a part of this? How can we do that on admission with the pharmacist and the virtual nurse at the same time, hearing it, correcting what needs to be corrected, so we don't have the downstream impact that we often probably still see with MedRec. It's probably on everybody's issue board or huddle board within your system, because it's always an area of opportunity. So we're really hoping to have a virtual pharmacist integrated, so incorporated during a time of med review into our program. We are transitioning to the two-way cameras. Like we mentioned, we had the one-way, two-way. We're so excited. Delaware has already started to convert some of their beds. We hope in about a month to start our conversions in Florida. So that's just going to broaden that connection that we feel like we'll have with the families, and the ability to see and assess and do other, you know, tasks that we're currently are limited, but certainly has not been, you know, a deterrent to launching our virtual nursing program, which has been great. And looking next as well as a specialty model. So we started early conversations, but what does an enterprise hematology oncology virtual nurse look like? Someone who's specialized and has that skill set. What can they do beyond our current Venn diagram? And what are some other services, endocrine perhaps, or the rehab, that if you have someone truly skilled in their specialty, what could we do? And if we don't have the volume in one, this is an enterprise approach where those nurses will support the service line within both hospitals. So really excited to continue those dialogues of expanding in a different way.
Sophie, I'll just add, I think the other part about this that we're realizing, as we have so many nurses who are new to nursing, this has been such a unique opportunity to involve a support structure for mentorship. So as we, you know, we have the cameras up and running, able to use, as we think through the first time a nurse is giving discharge education, or they are talking through a specific medication, or how to perform X at home, to have the ability for the virtual nurse to pop up on the screen as a support through that, as a mentor through that, is huge, and something that I think we're also realizing as we expand to a full-scale model, and then also support our future from a care team overall.
Thank you, Liz. Great call out. And this is a look into our future, as we've mentioned, those two-way cameras. So just a glimpse into the, you know, the platforms that we'll be utilizing. Again, proud of our start, that we didn't wait for this, but very excited as to how this can continue to strengthen and grow the program, improve the visibility. And then down the line, right, there's potential for AI integration. And what does that look like? And how does that augment the work of a virtual nurse? And next, these are some exemplars, really short snippets from the virtual nurses. They're in their words, you know, the encounters that they have had, the success stories, and really what is filling their bucket. You know, what are they finding and what are they seeing through this program that they haven't seen from a bedside perspective, sometimes that forest from the trees. So we have caught many, I know, instances of discovering legal guardianship. That's a big thing in pediatrics. And oftentimes at the bedside, when you're ready for signatures, when you're asking sometimes those questions, and it's been so great to have that proactive lens within taking their time and the quality of asking those questions of the admission database, or as you move through, of having and identifying the people truly and their right relationship with the patients. The duplication of meds, we have talked about having the, those paperworks not matching insecurities with food insecurities, any of the social determinants of health. It is so rewarding for them to find that positive screen, to have that very vulnerable conversation when families are opening up, and then to be able to do something about it, to move that forward, to get them the help that they need. It's not simply related to the medical care, but the care of the whole family as a whole. Instructions that were wrong within any of the notes or discharge instructions and that were caught. So many little snippets, love to share, take the time, but it's what is rewarding about the program. And here are some more, again, more snippets from the staff. And I think when I talk to them, there's one theme that you hear of most of them say at some point, and it is, I thought I was doing a good job. I thought I knew how to complete an admission database. I thought I was thorough. I thought I was providing the best care to my patients when I'm discharging. And it's that realization when you step away into a program like virtual nursing, where you get to slow down. When they have a patient, that is their one patient at that time. The active listening cannot be compared when you're at the bedside. It can't be. And there's no fault, right? As a nurse at the bedside, you've got your devices that are connecting you, the call bells, the alarm escalations, the conversations, a walk by. There are many distractions and interruptions. And for the virtual nurse on that headset, when they're speaking to a family, that is their only patient at that time. They are fully engaged in hearing what's not being said in between and being able to expand. We see that, as Liz mentioned, through the data we're getting from a patient experience, but also in what they are hearing and finding and being able to do for the families. The success of the program now continues, and we are learning now that shadowing the virtual nurse is something we need staff to do. So we now have integrated spending a shift with a virtual nurse for all our new hires, absolutely for our nurses, but many of the residents now, we're engaged to our GME, and they're bringing in their residents to, have a few 4-hour blocks of spending time just so they understand and can see, because it is so new. And I think until you see it in action, it doesn't all connect, and then you can work together. Once you understand each other's reality and have those questions and conversations, we can move forward with the improvements. And I believe that is all. Thank you all for listening, and we'll move on to questions now.
Thank you both. That was a very rich presentation. I see the chat blowing up with a couple questions, so I'm going to scroll right over. Mary Lynn is seeking some clarification. You took bedside, helps if it doesn't move, took bedside nurses and placed them in the virtual nursing role, meaning you reallocated an existing nurse rather than adding one. And then the staff perceived this as an added resource. Is that a correct summary?
Yes. So when we launched in a budget neutral fashion. So yes, we took hours per patient day from that unit and built in our virtual nursing model from that. So that's how we, launched that program. It is, it shifts per unit. Everyone will find the work that fits, but we launched it with staffing resource pool nurses who are already there that now trained into this other role that is a complement to the bedside care. So they were a resource to them and being able to off shift some of the work from the bedside in that process.
Excellent. And I heard you mention budget neutral, so that does tie in another question that we had. There is an attendee today. It says they're doing virtual nursing in their NICU, primarily for mentorship and staff support, and they would like to hear about ways to show financial value to senior leaders because we are all worried about that bottom line.
Yeah, so two things. The first, to piggyback on what Sophie shared, that one size fits all. We are doing things a little bit differently in Delaware. We have virtual nurse 1.5 FTE per the 2 practice areas that are currently up and running in Delaware, and we are building them into productivity on a daily basis, Monday through Friday, for that 10 to 10 shift. And so from the financial end of it, I think a few things. First and foremost, I don't think you can, and you know, I wish that we really could show the whole picture about preventing harm in this ability, again, to slow down, provide really accurate education, medication education, education to prepare for discharge, and then also that collaboration around IV infiltrate prevention, PIVI prevention. You know, the role of the virtual nurse when it comes to your central lines, educating the family, pulling the care team together, overseeing maybe care. And so when you think about harm prevention and the role of the virtual nurse, coupled with the fact that we have approved efficiency around discharge and approved readmission rate, to me, those are some of the financial indicators, coupled with the fact that we are changing really the staffing model in a way and not adding another nurse to the mix. We're actually using what we have for now. Again, that might not be that's not one size fits all. We have to adjust along the way. And Sophie's partnership in this to think through, do we have a virtual nurse that covers hematology oncology collectively in both organizations, or rehab? You know, how does that look different based on the patient population?
Yes, excellent. Thank you. Very thoughtful response to both questions. I know there is some excitement in the chat. They want, our attendees want to know, what are the possibilities for maybe international nurses or nurses to provide services across state lines virtually? Is this opening up borders, or what insight do you have? I know that's kind of a larger question.
Yeah, I can kick off, and Liz, please chime in. I think, you know, to start, there's going to be your state, how they regulate, right? Your practice at within those states. So we were fortunate that Florida and Delaware, which are the 2 freestanding hospitals in our system, are part of compact licensing. So we could have a nurse with a compact license and they could provide care for patients in both states. So that's all gonna, you know, that's one of the sort of fast ways to get there if you have a state with a compact license, but that's going to take, to broaden that, a legislative push to do anything differently to allow these sort of services.
Yeah, definitely. The role of technology and what we can do is in a lot of different hands to determine. One final question before we get into the closing housekeeping remarks. I'm wondering if you can share any strategies you had around engaging those that were maybe not as excited about the program, some of those late adopters, some of those neither agree or disagree type respondents. We know we love to work with those that are excited, but even those late adopters, we have to get on board. So any thoughts on how to engage them?
Oh, absolutely. Because you're going to have them. Anyone who thinks they won't, then you're in denial, because they absolutely, with any change, you have those who are resistant or just not bought in, right? They're used to their ways of doing things. So we encountered and still encounter. I mean, that's going to be a continual thing as we grow and have new units come on board. We're going to repeat that cycle all over again about what are we doing and why are we doing it? And I'm good, you know? So I think for us, when we first started, information, education, right? Letting them know why we're doing this. And what really started to change our tide in all of this was being able to share the results of things that we're catching, right? To share the stories of their great catches. Those are the first things, because that's pre-data, right? Because the data will come over time. You have to build those infrastructures. So it was those patient stories, giving them that connection to things that probably would not have noticed or missed because we weren't practicing in this way before.
Mhm.
Those are the first things. So I think highlight any chance that you get. You've got to share your success stories for them to understand. Continue to talk about it, and then you'll add on the data elements. Because once you have a data elements, it's really hard to argue about something that is demonstrating outcomes. Once it's there, it's there. And then at some point this is how we're doing it. It is no longer a pilot, a test, or an option. This is our model of care. We will give you feedback if you didn't, right? Follow that process, and then we'll have a different conversation. So it's a journey in getting there.
Yeah. I think just one thing to add to that, Sophie, is so well said, is that we were very thoughtful around small tests of change and piloting. And we had that survey at the fingertips of our clinical teams to provide us feedback. And we made adjustments along the way, which clinical teams saw. And I think appreciated that we were listening, that we realized this was a transition, but that we were going to get there together. So I think that was also important for us, for, our early adopters, plus those who might, have wanted to sort of wait and see.
Thank you both. Yeah, I love everything you said. Those small tests of change, celebrating those small wins, and bringing in the personal while the data is still growing. And yeah, like you said, change is a journey for each and every one of us. So it takes a team to get through it. I believe that does wrap up our presentation for today. You do see the email addresses of our presenters there on the screen. They're also in the slides that were on the email this morning. And, worst case scenario, feel free to email team training and we'll get you guys connected. As a reminder, those who attended live, you are able to get 1 hour of CE credit for this presentation. Make sure you have your Duke OneLink account set up. And then I believe the code for today is FATD, as in David, UR. And that text will go to 919-213-8033. Yeah, like I said, feel free to reach out to us or our presenters with any other questions, comments, insights, conversational starters you have on this project or anything else team training related. Otherwise, we will see you next month or next week or at another future team training presentation. Thanks again to our presenters, Liz Salerno and Sophie Rodriguez of Nemours Children's Health. And have a wonderful rest of your Wednesday.
Thank you.
Thank you.